produce cure. By the same time, the chemotherapy is invented for the leukemia management. So, by utilizing the chemotherapy into the breast cancer management, especially after the surgical management, many got cured. Chemotherapy is basically drugs. They are intended to act on the nucleic acid and cell cycles of fastly growing cells. Fastly growing cells in the sense the speed which cancer grows. Unfortunately, some of our host cells also fastly growing. So chemotherapy is relatively non-specific. So cancer cells are getting destroyed as well as the host cells. So there are some adverse events. Now we have technologies to sequence the cancer cells to identify the targets for a specific tumor. For specific tumor, the specific target, if we give the specific targeted agent for that, we will get more cell kill and less adverse event and very good results. So we entered into the era of targeted therapy after 1980s, and the very recent one is immunotherapy era. Immunotherapy is also drugs. Most of them are injectable, and by using the drugs, we are basically remove the checkpoints, our immune checkpoints, specifically in a controlled manner, so that we can utilize our own immunity to destroy these cancer cells. The last one decade full of immunotherapy drugs, and it is totally changing the paradigm of cancer treatment. So with this background, we will move on to the topic, that is inoperable breast cancer. It is inoperable because of size, invasion or metastasis. So we can divide them into locally advanced breast cancer or metastatic breast cancer. Traditionally, breast cancers with skin involvement or chest wall involvement, matter nodes, supraclavicular nodes, they are classified as locally advanced breast carcinoma. Why they become inoperable? This has to be known. Most of time it is personal negligence. Do you know one thing? In US, the most common cancer is breast cancer. In India also, the most common cancer is breast cancer. But when you look at the list of death-causing cancer, in US, the breast cancer has 4th place. But in India, it is top the chart. Even now, the most important reason is this personal negligence. We have to build more awareness to bring our patients to come at early stage so that we can completely cure them. Another one thing is the awareness of screening mammogram, which is very low in India. In Western countries like US, after 40 years without mammogram, the lady will not get salary. So they are doing. When they are diagnosing 100 breast cancers, around 30 they are mammogram detected. Do you know one thing? Screening mammogram can detect breast lump before it is clinically visible. So basically it is stage 1. So the stage 1, we know that cure rate is around 95%. So they are curing more. In India, when we diagnose 100 patients, almost 30 patients, they are locally advanced. Their cure rate is around 60 to 70% only with the best available treatment. So we have to build the awareness, and some things are not in our hand. Even the patients who are doing a regular mammogram, some interval cancers like high risk, high aggressive biologies like triple negative, HER2 positive tend to happen. That is beyond our hand. The thing with our control should be done properly. So we are seeing a inoperable breast cancer. How to work up? Easy. We have to do the diagnostic workup and we have to do the staging workup. So Sir told that diagnostic workup is do a core needle biopsy, do a IHC testing. IHC testing should include the receptor status and proliferation index. Staging, here it is very simple, it is not complex, it is inoperable. Most of the time they are locally advanced. The best investigation is PET-CT whole body if it is available, because it will be more convenient, single contrast, and we will get the ultimate stage with us. If it is not available, then we can go for contrast enhanced CT chest, abdomen and bone scan. Bone scan is also again tricky. Bone scan is also not available in many third tier cities. So whenever it is possible, do that bone scan. Another problem with the bone scan is to pick up a bone metastasis in the bone scan, there should be some sclerotic meds. Pure lytic meds will not be picked up in the bone scan. Okay, and one student has been asked that skeletal survey. The problem of skeletal survey is to be picked up, bone meds to be picked up in the skeletal survey. There should be at least 30% cortical destruction. Then only it will be picked up. So by doing a skeletal survey, there is no meds. It doesn't mean that the patient doesn't have the bone meds. Okay. Another indirect marker is when you don't have any bone scan or PET-CT, you are a resource limited setup, then you can look at the alkaline phosphatase. Okay, the alkaline phosphatase, even in the early breast cancer, as sir told, there is no need of CT and PET-CT, but after doing a chest X-ray and ultrasound abdomen, you have to look at the alkaline phosphatase. Okay, the alkaline phosphatase should be normal. If the alkaline phosphatase is high, the likelihood of bone mets is high. There you have to go for either bone scan and PET-CT, even if it is early breast cancer. So we have done the diagnostic investigation and we have done the staging investigation. And one more point, whenever you diagnose a breast carcinoma, we need to do the bilateral digital mammogram. I agree. But if the patient is having LABC, especially the ulcerated lesion, there the affected breast, there is no need of mammogram because it will be more painful for the patient. And if in that case, the opposite breast mammogram should be done, but the ipsilateral mammogram can be avoided. So we have done the diagnostic workup, we have done the staging workup. Now it is the time for team approach. As sir told, the multidisciplinary tumor board approach is the best one to bring more good results than individual approach. Ideally, that team should include a oncopathologist and radiologist. So we are sitting with the team and we are devising the plan. So we have diagnosed a locally advanced breast carcinoma, which is stage 3, no metastasis. What is the plan? Most of the time, we need to give the systemic treatment upfront. As I told, it is a systemic disease. Breast carcinoma is no longer a loco-regional disease. So before planning a systemic treatment, first we have to clip the disease, because we have very good chemotherapy agents and targeted agents. It will melt the disease. We have seen many clinical complete response. In fact, in the HER2 positive group, properly given neoadjuvant treatment, there is 50% chance to have pathological complete response. So you have to clip the disease, then we have to start the systemic treatment. Here also, traditionally the chemotherapy, they are used to given with anthracyclines, cyclophosphamide and taxane based one. Every 3 weeks, generally 8 cycles. But the recent advances that include the dose dense approach. Generally these chemotherapy drugs we used to give every 3 weeks. But when we give in every 2 weeks, that is dose dense approach, there will be more cell kill, deep response and quick response, provided the patient should be fit enough for the dose dense. So when we see a fit individual LABC, we prefer dose-dense chemotherapy with appropriate supportive medications. Next, the biology. If the patient is having F2 positive type, we have a target in our hand. We have the plenty of targeted reagents for the F2. Especially the previous decade, we used to give trastuzumab along with the chemotherapy to produce the response. But in the current decade, we are giving dual targeted therapy, that is trastuzumab and pertuzumab. Trastu, pertu with chemo, there is 50% chance to have pathological complete response. Those who are achieving that pathological complete response, they are highly likely to get cured. And so the SAR has asked the yearly breast cancer, why we are now pushing the neoadjuvant chemotherapy upfront? Because neoadjuvant chemotherapy will downsize the tumor. Doesn't matter for the yearly breast cancer, but matter is the yearly addressal of micrometastasis. So the late recurrence chance will be reduced, and the chance to have breast conservation surgery is high. Those who have pathological complete response with the neoadjuvant chemotherapy, they are highly likely to be cured. So whenever opportunity arises, better to give the neoadjuvant chemotherapy. So the treatment approach is getting changed. Next comes the triple negative breast cancer. Triple negative breast cancer, we often prefer dose-dense neoadjuvant chemotherapy. Now the recent addition to that is immunotherapy. Immunotherapy, as I told, it produces wonderful responses, results. But in breast cancer, the TNBC is the only subtype which beautifully responding to the immunotherapy. Adding immunotherapy to the neoadjuvant chemotherapy, there is high chance to get pathological complete response and cure. So with this, even LABC, it is getting cured with the appropriate systemic management followed by the surgical management. Of course, all should be delivered with the post-mastectomy radiotherapy as well. And what about the metastatic setup? 20 years back, we had few chemotherapy options, 2 hormonal options. That is not the scenario now. We have plenty of targeted therapy options, immunotherapy options, and even hormonal options, the new options being raised. So with this, even the stage 4 breast cancer, they are living happily beyond 5 years with good quality of life. That matters. And those who are the hormone receptor positive and even with multiple bone metastasis, there is no visceral crisis. Visceral crisis means the metastatic, the organ, it produces symptoms or it produces the signs of failure, then it is called visceral crisis. Most of the time, hormone receptor patients, though they are metastatic at the front, they won't produce much symptoms. There won't be any visceral crisis. That patient easily get managed with the only hormonal treatment without chemotherapy. And we can add the targeted agents like CDK4/6 inhibitors with the hormonal options, and easily we can cross 3-4 years without chemotherapy. When all the hormonal options are being exhausted, that is the time we can think of chemotherapy to that patient. So with that, the crossing 5 years is very easy for, especially for the hormone receptor positive metastatic breast carcinoma. Next comes the HER2 positive. HER2 is also, initially we had only one drug, that is trastuzumab. By giving the trastuzumab along chemotherapy, the survival got lengthier. In fact, the previous to the discovery of the trastuzumab, the subtype with HER2 positive, they are categorized as high risk population for the recurrence and poor prognosis for the survival. But after discovery of this trastuzumab, the paradigm is shifted. Now those who are expressing the HER2 receptors and who can be given with the HER2 targeted agents, their response is great, their cure rate is great, their survival is great. In fact, more and more targeted agents like antibody drug conjugates have been already one is in the market, that is TDM1, and another one is coming in the faster way and produce wonderful response, that is trastuzumab deruxtecan, and we have plenty of small molecule inhibitor for the HER2. So with these, their survival is much better than the previous days, and they have very good, even the HER2 receptor, they are called as HER2 new, because it has that receptor has the tendency to be expressed in the brain also, and they are prone for brain metastasis also. Even those having brain metastasis, with the usage of the small molecular inhibitors, they are living long. Generally, those patients with brain metastasis, their median survival is 6 months. But these patients are living more than 1 year and few years with this proper usage of these small molecular inhibitors. And triple negative breast cancer is always a nightmare. It will respond beautifully in the initial time, but after some time recurrence happen and they will be died of disease within few months to a year. But here also we are now utilizing the immunotherapy. As I told, compared to other breast carcinoma, the triple negative is relatively hot and it produces much better response with the immunotherapy. And the latest addition in the triple negative breast cancer is PARP inhibitors, especially those who are having BRCA mutated, they are benefited a lot with the usage of PARP inhibitors. The last 20 years, many things have been modified and we have exciting newer drugs in the pipeline. The future is more exciting one, and more slowly we are moving into a personalized care. Now we have the technologies to sequence the cancer cell. Single cell sequencing will bring the genetic event which causes that particular cancer. By knowing that, we have handful of targeted agents to use to that particular patient and bring maximum response and survival. So we are slowly moving into a personalized care approach. Not all CA breast patients are same, they are molecularly different. And currently we are utilizing the molecular technology advancements like doing a liquid biopsies to know the emerging resistant mechanisms, and appropriately using targeted agents with that resistant mechanism, we can prolong their survival. And genetic testing, we have handful of patients. There are guidelines whom to you check that the germline variants of BRCA, we are checking properly. We have 3-4 patients already with germline BRCA mutation, and some of them have undergone the risk reduction surgery also. So they are previously, we don't know why this patient is all of a sudden developing the another breast carcinoma. All of a sudden they are developing a ovarian cancer after 5 years. Now we have answers and we have the technology to discover what genetic event is causing this cancer. And newer drugs are coming, and the precision medicine, especially the AI guided approach, is going to happen. So with this, the key takeaways: inoperable breast cancer is not equal to untreatable. LABC is not equal to uncurable. Metastatic breast carcinoma is not equal to game over. We have good systemic options even to bring cure and survival to this population. And the multidisciplinary tumor board approach is the opt one to bring the maximum results. Thank you. Any questions? I'm ready. The surgical response is after the surgery only, sir. Surgery only, the specimens should be studied under the microscope to say it is pathological complete response. Before that, we can say it is clinical complete response by examination and radiological. Generally, after a neoadjuvant therapy, we are not doing routine radiological re-evaluation. Only the clinical examination will give us the proper guidance. Yes, sir. Sir, if it is metastatic breast carcinoma, we tend to check with the regular re-evaluation with either CT or PET-CT. There the metabolic activity will give you some answer. But pathological complete response should be confirmed by the pathologically only. Can we take it as clinical complete response?
Cost effective, how much immunotherapy and
Immunotherapy, it is costly actually, but the good news is till 6 months back, the cost of the immunotherapy is per year is 10 lakh. Generally, this patient tends to have 1 to 2 years of treatment. Now, many newer agents have been coming up in the market. Their cost is coming down. In fact, when the trastuzumab is introduced into the India, the one vial cost is 1.5 lakhs. Now it is available for 15,000 in the matter of 10 to 12 years. Okay, this will happen to these immunotherapy agents as well. Now we have options that matters, and the cost will come down in the future. First, not all breast cancer, especially those are told, right, that hormone receptor positive breast cancers, if there is no negative, we can avoid chemotherapy in some subpopulation by checking the gene expression profile. First, so we are avoiding. In fact, after the surgery, we tend to do the gene expression profiling, and one population they are not at all receiving chemotherapy. They are jumping to the hormonal treatment, and the RT is required. Given chemotherapy, we have options like it's all most of them are middle-aged. So with the current supportive medications like filgrastim, the GCSF support, the appropriate antibiotic, and monitoring, the life-threatening complications are very less with the breast cancer systemic management. For head-to-targeted agents, there is some chance of reversible fall in the left ventricular EF. That will be monitored every 3 months with the echo. Even if the EF is coming down, if it is more than 10%, just holding the drug for 1 month, it will come up to the normal baseline and we can resume the treatment. So the life-threatening complications are very less with the breast cancer systemic management. Generally, the previous guidelines tend to say any triple negative breast cancer less than 60 years, any breast cancer less than 50 years, better to go for germline testing. But the current guidelines, all breast cancer patients should go for germline BRCA. Why? Because the previous guidelines identified those who are having the risk of contralateral breast cancer, risk of familial tendency. But now, addition to these points, we have therapeutic advantage. Those who are having germline BRCA mutation, they should receive 1 year of PARP inhibitors. Their cure rate is very high. So, this therapeutic advantage should go to the patient. And we have the panel testing, which is available for 12,000. So it is easily available. So we have to utilize the germline BRCA testing for every breast cancer patient. Ideally, if not so, at least for the triple negative less than 60 years, all other breast cancer less than 50 years.
Sir, why chemotherapy and endocrine therapy are not coupled together, sir?
Not
simultaneously, why chemotherapy and hormonal therapy?
Very nice question. Basically, chemotherapy is a cytotoxic one. Hormonal options are more of cytostatic options. There are trials which showed that combining these two compared to the sequential chemo and hormonal treatment, the survival was little dismal. Some studies, And some studies we have, there is no big difference. Even now coming up a metastatic breast cancer trial, where they given a oral chemotherapy with oral hormonal options, their survival was on par. So, as a habit, we even now avoiding the concurrent hormonal and chemotherapy option, rather we are giving a sequential option.
Sir, in neoadjuvant chemotherapy, after 2 cycles we evaluate for the response, sir. So if there is complete response, do we complete the neoadjuvant chemotherapy or go for upfront surgery after?
Excellent question. Thing is, first we should know the purpose. In what purpose we have started the neoadjuvant chemotherapy? If it is early breast cancer and triple negative or HER2 positive, our purpose is to bring the patient to the pathological complete response. For that, for HER2 positive breast cancer, we should give at least 4 cycles of HER2 based regimen. Then only we have to go for the surgical management. For triple negative breast cancer, ideally you complete all the neoadjuvant chemotherapy upfront, then go for surgical management. Here also we have two purposes on this. First of all, we will know the in vivo sensitivity and the pathological complete response, whether it is happening or not. Those who are having pathological complete response, they are likely get cured in the later time. So prognosis you will get. Second, here also there is a therapeutic advantage. Now, after receiving at least 4 cycles of HER2 based regimen as a neoadjuvant, then you are undergoing a surgical management and you didn't achieve the pathological response. That patient will have some adverse outcomes. These patients, instead of giving trastuzumab maintenance for 1 year, we have to give trastuzumab emtansine, that is TDM1, it's an antibody drug conjugate for 1 year to improve the survival. Second, in triple negative breast cancer also, after adequate neoadjuvant chemotherapy, if we didn't achieve the pathological complete response, that patient should receive 1 year of capecitabine, that's a create-X trial. That patient should receive to get high chance to get cured, at least to get the high survival. So it has 2 motives here, prognosis as well as therapeutic. So the HER2, at least 4 cycles of HER2 based regimen, triple negative, really you have to complete all the neoadjuvant.
Thank you, sir, for such an
Thank you.
insightful session. Carrying the momentum forward, it's now our pleasure to welcome another distinguished expert in the field of oncology.